So we started last week with talking about fetal monitoring in special circumstances. We talked about meconium last week, okay? And we saw how we initially got it wrong because meconium was not about hypoxia, but it's a different pathology, even though there is some hypoxia involved, but there is a bit of different pathology as well. This week, we're going to be talking about pyrexia and sepsis. And I'm very proud when I come to talk about pyrexia because obviously this was the biggest achievement I think that we have achieved all over since starting physiology. We started recognizing why babies become unwell with pyrexia and sepsis. So let's start off with what is pyrexia?
Well, it's a debatable question, but it's essentially a temperature of more than 37.8.
37.8. That's a very specific number.
I know, that's what the medics use. I think it's a good number.
Okay. I mean, most units agree that it's temperature twice over 37.4 or a temperature over 38. One or more over 38. Yeah? So what causes pyrexia during labor?
Well, labor causes pyrexia.
Labor causes pyrexia, as in the effort and the work in labor, yes. But whenever we talk about pyrexia, what's the first thing that everybody thinks about?
Infection.
Infection, yeah, sepsis. Okay, but other things can cause pyrexia, like an epidural, like prostaglandins, as you correctly said, labor itself. We've all been on labor wards when the moment that the sun is shining, yeah, the rooms turn into a furnace. Poppy, I think there's a bit of feedback.
Oh, sorry.
Sorry. So, but why is pyrexia important? What makes pyrexia so important? You all know that I have a little bit more time on my hands. So this is an experiment that I did at home. So very, very crude, yeah? Some egg white and just some warm water, a warm water bath, and we'll slowly heat it up, okay? Remember, our baby's brains and our brains are formed of proteins and lipids predominantly, yeah? So let's see what happens to protein as the temperature rises. Can we all see the temperature on the thermometer? Now, this is shown real time. The idea is to make sure that I'm not skipping any steps. I'm showing exactly what's going to happen and at the speed that it's going to happen. So 26 degrees. Now, what's our normal body temperature? 36.5 to 37.4, yeah? So we're approaching normal body temperature now. Egg white seems very clear, but look at what happens once we actually exceed the 37. Can you see that white rim developing? What do you think is happening there? What's happening to the protein? It denatures, yeah? So temperature is now approaching 40 degrees. Now, temperature above 40 is called hyperpyrexia. And that can lead to permanent brain damage. Can you see that white trim darkening? Can you see that? Okay. Now we're going to keep the temperature between 40 and 42. So that's it. Actually is now going to settle back to 40 again. We're going to keep it at that temperature, so above 40 for 5 minutes, sorry. Okay. Can you see now most of the albumin is now denatured? Okay, leave it for another 10 minutes. It's properly cooked. Did you see that? So that's 10 minutes of a temperature just over 40. So the high temperature causes denaturation of proteins, and this can lead to permanent brain damage. Remember we said 37.442 for over an hour, yes? How long should you wait when you know that the temperature is already raised? Should you wait for 5 minutes, immediate, 5 minutes, 10 minutes, an hour? Okay, now remember, baby's temperature is 1.5 to 2 degrees above maternal temperature. So if mom has a temperature of 38 degrees, baby's temperature is 39.5 to 40. If mom's temperature is 37.5, baby's temperature is around 39. Okay, and if this is because of sepsis, or this is because of chorioamnionitis, the temperature is actually starting in baby. Mom is presenting late. So how long do you think baby has been pyrexia for? Okay, the egg that I was showing was a healthy egg. There was no infection involved. This egg was not septic. Sepsis and pyrexia have a synergistic effect. So if there is an infection, the infection can cause damage in an entirely different pathway than the temperature. But when you put them both together, that's a problem, because then you have stronger damage. You have much more damage. So how do we treat pyrexia in labor? A question to the audience?
Paracetamol.
Yeah. Paracetamol is usually very, very helpful. Yeah. How do we give it?
IV.
Why not oral? I thought oral and IV work.
But you have reduced absorption on your labor.
Takes a delayed effect and it's not systemically effect very quickly.
So if you have a delayed absorption, as Fatima said, and if you have a slight rise, that you're not going to have that much of a systemic effect. Okay, it's going to be very, very late. And remember, gastric emptying is super delayed in pregnant women. 6 hours is usually not enough. But if you give a paracetamol for it to be absorbed in 6 hours time or in 4 hours time, that's not going to do anything to help. So give it IV, please. The other thing is the rapid rise in the paracetamol level means that it's also going to cross to baby, and that means that baby is going to have some antipyretic effect on baby as well. Most of you have seen me doing IV paracetamol on labor ward. I love it. It brings back the baseline when we don't know why it's gone up. Is there anything else that we can use as an antipyretic in labor apart from the IV paracetamol?
Voltron.
So Poppy was just saying antibiotics. Antibiotics don't bring the temperature down.
Voltron.
Voltarol, yes, so non-steroidals. Non-steroidals are very strong antipyretics. But why don't we use them on labor ward? And why don't we use them in labor?
Because everyone is fearful about the ductus arteriosus.
Because we're worried about the ductus arteriosus. Okay. So what does Voltarol do to the ductus arteriosus, Mukhtar? It closes it, yeah? What does that do to the baby? So what? So what happens if the ductus arteriosus closes? It's not good. It starts closing within 4 hours. Okay, so diclofenac starts making the ductus arteriosus tighter within 4 hours of it working. If you have a closed ductus arteriosus, the problem is, remember, this lung is not inflated yet. Hence, the pressure within the lung is actually quite high. So this baby has a pulmonary hypertension. That's what interrupts the circulation. So these babies have severe pulmonary hypertension. However, this baby is supposed to be delivering within the next couple of hours anyway. This baby's ductus arteriosus in the next 4 hours should be closing anyway, which is why we can give it as a very last resort if I'm considering that this baby is going to be delivered within the next 4 hours. Is there any other medication that we know that can close the ductus arteriosus or causes severe stricture of the ductus arteriosus? Because everybody's panicking, we're always panicking about diclofenac or non-steroidals. So prostaglandin keeps them open. It's the antiprostaglandin effect that closes it. Okay. Can anyone think of a medication that causes closure of the ductus arteriosus? I'm gonna take my AirPods. Guys?
Mifepristone?
No. Why would they use mifepristone in a pregnant woman?
I don't know. You were just asking in general. I didn't understand.
Okay. The thing that actually causes the biggest stricture of ductus arteriosus is steroids, betamethasone. Betamethasone has a remarkable effect on the ductus arteriosus. It makes it really, really tight. So when you're comparing diclofenac, you're trying to see how much of the betamethasone effect does it have. Okay? Yet we give it 12 hours apart, blah, blah, or 24 hours apart. The idea is it prepares baby's lungs. The whole point is that diclofenac is not going to affect the ductus arteriosus so badly that we're going to damage the baby. It is safe to use it if this is a last resort. Okay? The very important point is make sure that you have not, there is pyrexia. You have not reversed the pathology. You're just trying to buy time to get this baby to full dilatation safely. So always make sure that you are getting there. And if she's fully dilated or almost there, consider operative delivery sooner rather than later. Does that make sense? Now, remember, this is all about pyrexia. Pyrexia, regardless of the cause, can be damaging. But if we are talking about chorioamnionitis, that and sepsis can have a damaging effect in its own sense. Let's start with the basic question once again. So, what's chorioamnionitis?
Infection of the chorioamnion.
Infection of the chorio and amnion. So, infection of the chorionic membrane and the amnion. Yes? It is usually due to a bacterial infection. So, when we talk about clinical versus subclinical, what do you mean by clinical chorioamnionitis?
Someone missing clinical evidence of it, so pyrexia, raising baseline.
So when we can see clinical evidence of infection,
yeah.
Who are we monitoring?
The mother and baby.
Yes, but the person who we're normally looking for signs in is usually the mother. That's the person who we're normally monitoring. And that's why actually subclinical chorioamnionitis is when baby is showing signs. The proper person who's actually supposed to show signs is actually showing signs. And now we're finally recognizing the signs of the tachycardia in the baby. Okay. And now we're starting to say, this is chorioamnionitis now that we're monitoring the baby. Because what we always, or the person we always used to monitor is mom. And we used to say, well, yeah, the baseline has gone up, but mom's temperature is fine. Because mom does not have an infection herself. Chorioamnionitis is an infection in baby. Okay? Hence, the baby will respond first. And historically, we used to call this the uncomplicated tachycardia. Would you ever look at a lady who has a heart rate of 120 and say, your heart rate is fine, it's tachycardic, but you're uncomplicated? That's normal.
I mean, occasionally, I think very rarely, but yeah.
Would you?
No, probably not.
Anyone else? Would you ever look at a mom who has a heart rate of 120 and say you're fine? Most of the time, no. Yeah, so there's nothing uncomplicated about the tachycardia. Babies are not stupid. Yeah? Now, maternal pyrexia due to chorioamnionitis means that we have enough infection to infect baby and spread the infection around to everyone else. And if we stay a little bit long enough, the midwife in the room is going to start becoming pyrexia, and maybe her partner at home. Okay. Maternal pyrexia that happens before the baby's heart rate goes up is usually because of maternal infection. So if mom's heart rate is going up or her temperature is going up first and then baby follows, that is because of mom. That's an infection, that's a UTI or a chest infection or something else. But it's not usually chorioamnionitis. Okay? But always remember, temperature is damaging within itself. Okay. Does that make sense? Guys online, can you still hear me?
Yeah, makes sense.
Yeah. Okay. Can we treat chorioamnionitis? Apart from by delivery, but I mean, that's not treatment of chorioamnionitis, that's delivering the baby. Can we treat chorioamnionitis? That's the question.
I don't. We can treat with like fluids.
We can treat with, I mean, this is an infection. How are you supposed to treat an infection? Antibiotics.
I don't know if it will make that much of a difference. So
the only antibiotic that is known to cross the placenta in prophylactic doses is cefuroxime 1.5 grams. That's the only one that we've proven that actually can cross the placenta enough to cause a prophylactic dose, but not a therapeutic dose. So the reality is we cannot treat chorioamnionitis in utero. Okay? Then why are we giving antibiotics? If we can't treat it, why are we bombarding women with antibiotics?
To treat the mother.
The mother has no infection yet.
She's scared. The doctors were told to treat with antibiotics.
We just give antibiotics to anyone.
In case there's another source of sepsis that we missed.
Okay. Anyone online has an answer?
Yeah, I don't have anything further to.
Is it that you're going to be treating the mum with the antibiotics that you give, but looking at that, presumably you're not going to be able to fully treat the baby?
So we can't treat the baby, but remember, this mum has an abscess within her abdomen at the moment. Yes? We are about to potentially open up this infection source, okay, by cesarean section, by delivering her, by even separating the placenta, opening all those blood vessels to the infection to rush through into her, in the middle of her abdomen. You're giving antibiotics to protect the mum from the infection that is about to spread within her abdomen. When dinosaurs still roamed the earth, before I was actually training, so this is the first time I'm not when I was training, just even before that, there used to be something called an extraperitoneal cesarean section, which means that you actually open the abdomen, you don't open the peritoneum, you peel the peritoneum off the bladder, off the uterus. So you're literally going underneath, okay? And that's only done when you have evidence of chorioamnionitis. That's a very, very historical thing. We don't do that anymore, by the way. Please do not attempt that. This is a dangerous practice. However, the reason they were doing this is to make sure that whatever lacquer is coming, infected lacquer coming out, goes immediately outside the woman and does not enter the peritoneal cavity. That's how dangerous chorioamnionitis can be to the woman, okay? But obviously they noticed that they were ripping the bladder open, they were damaging the bladder, they were causing lots and lots of damage and harm. So they stopped doing extraperitoneal cesarean sections, and now we still do it intraperitoneal, but we cover the mom with antibiotics to make sure that we're not spreading infection to her. Does that make sense?
Yeah.
Cool. How long can we wait with chorioamnionitis before we deliver?
Depends on the maternal temperature.
So it depends upon maternal temperature. Okay.
Well, I guess we've said we can't actually treat chorioamnionitis, so I guess it depends on how dilated the woman is, but you need to sort of imminently deliver her, sure, I think.
But do you have any idea about how long can you wait?
I'm not sure.
Okay. So there is no answer. There is no right or wrong answer. There is not enough research to actually tell us. And there will never be that research, simply because imagine that you're going to tell this woman, okay, you have pyrexia, you have chorioamnionitis, we're going to wait for the next 10 hours and see whether your baby's going to die or not. How much of your babies are going to have brain injury? What's the percentage of brain injury in those women? We really don't know. We can't answer that question. What we do know is that brain injury due to hypoxia, being 8 to 10-fold, there's a similar risk of injury due to chorioamnionitis of 8 to 10-fold. We also know that if they combine together, the incidence of damage is between 76 to 78-fold. So hypoxia and sepsis should never combine, okay, and should never be allowed to combine. If the lady is progressing really fast, try and take out all the other confounding factors. So bring her temperature down. Make sure that she is well, she is progressing, she is at the point, or she is carrying on. Look at the baby's CTG and see whether the baby's cycling, whether the baby's still coping. Okay? Don't push too hard, because that will add hypoxia to the baby. If she's progressing on her own and she's almost there, you think she's going to be delivering within the next couple of hours, you can give her a dose of diclofenac. That's an anti-inflammatory. That is going to reduce the inflammation process. It's going to slow it down. Okay? It's not going to treat the infection, but it is going to give baby a better chance, and her a better chance of a vaginal delivery. Okay? But if you're thinking it's going to be going on for hours and hours and hours, then absolutely not. Okay? You will end up with a much damaged baby. Does that make sense? So don't lose sight of the full clinical picture.